Welcome to Being Built. Josh Gratsch, thanks for being my guest.
Yeah, absolutely. Thanks for having me.
We're talking about cell phone habits.
I mean, working from home, being a father and a husband, one of the challenges you see of like kind of being able to separate the various environments.
It's tricky, man. Yeah, so like, there's my kitchen. There's my living room right there. Right. And how do you compartmentalize those things? Thanks, you're firing the questions. Like I stepped into your podcast, but that's a fun one. I'm glad you asked. I actually see it as an asset that I work from home, and it's difficult to compartmentalize my work in my home. I feel like there's something we lost as we evolved out of an agricultural economy and our home, families or whatever. The compartmentalizing of work and family, I think, lost a little bit of something. So my son is able to see my work ethic because my work is so saturated in my home life and vice versa. So I think that's a beautiful thing. Yep. Right. And so he sees me and hears me work in ways he wouldn't otherwise get to do if I was off to the office and then back home. And obviously, I think the ugly part of it is what you and I were chatting about before we turned the camera on.
Yep.
Which is it never turns off.
Correct.
And I'm always on and I don't have time for you. And I'm always looking at my phone.
It's very easy to wander back into the office and then suddenly it's like, oh, you sit down and then it's like, boom, you're back on your laptop. You're looking at work stuff or whatever the case may be. I found myself doing that last night. I had something on my mind. I went and did it real quick and then I did not get up. And this is like 7:30, 8 o'clock at night. And my wife's like, hey, can you get Maggie to bed? Like, yeah, yes, of course. Sorry. Shut the laptop, put the phone down, get out of the office. But it is like, I think there's inherent benefit to it of like the fluidity of not just purely being in an environment where it's, okay, go to the office, come back home, but kids being able to see what you're doing. And a lot of cases hearing you on calls and some of the leadership aspects of that. But then sometimes, like for us, I find value in having the office downtown and being able to go have that separate space, but we've stayed purely hybrid. So the majority of our team works remote on a day-to-day basis, and a few days a week we'll have a number of the team in the office collaborating on various things. So coming out of COVID, we never turned our policy back.
But there is something about sharing a space together, right? So I do get together with my very micro team. I do find value in actually slowing down a little bit and interacting in person. I also take advantage of some of the the hub and some of the other co-share spaces that are within a commutable distance. Because sometimes I just need a change of headspace changes as physical space changes too, right? And so sometimes I just need to break it up. And I like this little setup here.
Yeah,
but sometimes you just need something different.
That's right.
We were talking about, young kids and sports and all that kind of stuff, but you've got a lot of responsibility too. You run Ascend Innovations. Mm-hmm. How'd you get into it? Tell me a little bit about your background.
Yeah, so my background's in math and operations research. So my training is primarily in the data science realm. It's where I started my career. So the first few years out of college was in the DoD space, working at Wright Pat. Both as a civilian and as a contractor. Kind of got the range of experience there. And as a civilian, I was at a headquarters level in the Air Force Material Command. And in an analyses branch there wasn't a lot of movement on the work products and things of that nature. So I wanted a little bit more fast-paced environment. And so I went out and did some work on a Department of Homeland Security funded program that was collecting EMS data throughout the country and using that as a syndromic surveillance source for DHS analysts, which was interesting. We got to travel a little bit, collecting data throughout the country, driving some machine learning algorithms that were doing some work behind the scenes, and ultimately got me interested in healthcare.
What's syndromic?
Syndromic surveillance. So being able to detect, and this was pre-COVID, so being able to detect outbreaks of flu, gastrointestinal viruses, things of that nature. So just being able to alert analysts within the Department of Homeland Security who were providing more epidemiological surveillance across the country. The fun part for me was building the relationships with the EMS departments and just getting familiar with healthcare data. And it was at that time that Ascend was stood up. I was intrigued by the collaboration amongst the hospital systems in Dayton to stand up the company. The general positioning of the company to be able to have the opportunity to work within the hospital systems. And so I decided to make the move and started out at Ascend as a data scientist. And there's a lot packed within the story from there. I've been with the organization for 7 years, but long story short, the initial business model of the company was to source commercially viable products and technologies from within the hospitals. We had a team of biomedical mechanical engineers, and the whole point was to work with doctors, nurses, executives, whoever had an idea or the start of a concept, and work with them to commercialize that technology. Primarily focused on physical medical devices, needing FDA approval, long runways. It wasn't sustainable.
So when was that?
Late 2015 was when the company was formed.
What was involved in that? Premier
Kettering Dayton Children's. So the company's owned by Premier Kettering Dayton Children's through the Greater Dayton Area Hospital Association.
Gotcha.
Is the kind of foundational ownership structure.
That didn't pan out as planned.
It didn't. That business model did not pan out as planned. It really put me in a fortunate position to begin asking questions rooted in my background. If we're owned by the hospitals, could we get access to data for the entire Greater Dayton region? At that time, it was around 2017 when Dayton was labeled worst per capita in overdose deaths. And so the hospital said, yes, and we're going to challenge you to make an impact within the community to support the community health organizations that are tasked with responding to, at that time, the opioid epidemic, which obviously now has blossomed into a general behavioral health crisis. So we were uniquely positioned in that after getting access to hospital data to start to build those inroads to shift the business model to community health data and technology.
I think it's your spin out. I forget the name of the product. Positively that initially caught my attention, actually compelled me to invite you to be a guest on the podcast. So I think I shared with you in our conversation that my younger brother passed away last year. So I appreciate the work that Positively and Ascend did to address that or to engage with that problem.
I'll talk a little bit about the holistic business model of Ascend and where Positively came from.
Sure.
So Ascend is, like I said, community health technology meant to support the community health organizations responding to the most complex populations. So in Dayton, we were able to build relationships with Montgomery County ADAMHS, the Recovery Board in Dayton, as well as Public Health Dayton and Montgomery County. And in addition to the hospital data, building a more holistic data set that includes hospital data, jail booking data, coroner's records, interactions with jails, police departments, and using that as a foundational aspect of building solutions rooted in the data for the organizations that historically haven't had access to data to make decisions. So that kind of got our start in terms of becoming more of a consulting and service rooted business. But the uniqueness is, when we're working for some of these county or governmental organizations, we're able to retain the intellectual property for the solutions that we're building. So where there is an opportunity to build a solution that solves a problem at scale, we can look at productizing that. And so that is where Positively came from. Montgomery County ADAMHS came to us out of the initial part of the pandemic in the summer of 2020 and wanted to build a solution that was capable of providing resources to students revolving around mental health. And so we built an initial MVP centric to a distribution mechanism through the schools that provided two things. One was resources in terms of what's available in the community, what's available in the school. The second part was a forum for them to share stories, really focused on, okay, if you've had experiences with divorce, parents that got divorced, if you've had experiences with anxiety, depression, just allowing them a mechanism to share those stories for the purpose of building community around it, getting kids to realize you're not the only one. And so we started out with that, and it attracted CareSource's interest. They invested at the beginning of 2022, and then we sought out from there to expand upon that model to build out Positively through schools. We hit some barriers within the schools, really identifying that schools were not the right distribution method. Not all schools, but some schools were risk averse in terms of liability of, what if kids start talking about certain crisis situations and we don't have the resources to respond. So limitation of resource, not wanting to take on some of the liability of that, and primarily probably more rooted in just not having staff to respond to certain situations, made us step back and reevaluate the business model because we hadn't found product market fit by, I'd say, the fall of last year. So we've definitely pivoted a bit and expanded both the feature set and the distribution model for what we're going after here in the next few months.
Did it provoke engagement? Was it allowed to get far enough to provoke?
It did, yeah. So we had it piloted within the greater Dayton region. So Beaver Creek, Kettering, Fairmont, Northmont, Dayton City Schools. We had kids writing stories. They liked the tool in general, but what we needed was more than that. We needed engagement from the schools to really carry it forward and have it be impactful and produce outcomes. It was really the Dayton area was pretty successful in the pilot. We had a lot of engagement from the students. It was when we got outside of the Dayton area and close relationships where we really started to struggle, where we figured out that we needed to rethink the model and the approach and ultimately the problem that we were aiming to solve.
So what's next for Positively?
We know resources are important. However, the first iteration of the MVP was focused on providing a static resource directory. Static resource directories are incredibly powerful. They're everywhere. You get on any website for any provider, any nonprofit, like they're going to have a resource directory. And so what we wanted to do is create an approach to have more tailored resources tied to the needs of the individual. So we've created an MVP that allows us to take advantage of things like GPT and generative AI for quickly grabbing and distilling information and building a mechanism for experts. So it could be a therapist, a counselor, a school counselor, a provider, somebody that is engaging with teens or students to quickly provide tailored resources. A little bit different than, let's say you're leaving an urgent care with strep throat and they give you a printout for here's general information on strep throat. Not a big time sink for them, but it's not tailored to you. It is a generic, all ages, all facets of the condition, etc. What we wanted to do was take that and make it much more, one, approachable to the students, two, more centric to what their actual needs are. So that was the first part of evolving positively. The second part was figuring out through engagement with partners in the space was that there needed to be more of a digital community aspect of this, meaning that we could create digital communities around these needs of the different facets of the population and engage a mental health professional within that. So kind of a human in the loop approach where we would have a case manager, care manager, therapist, counselor, whoever is available to manage within those populations. And the biggest thing, getting a feedback loop from that to the provider or to the child welfare services. Again, whoever the organization may be that is interacting with these students and a part of that general continuum of care. So I would not say we have achieved product market fit yet. We're definitely in the validation mode, continuing some of the interviews and conversations and heading towards getting some pilot partners locked in.
It's a cumbersome and noble work. Let me kind of leapfrog back on our way to Ascend and question about the opioid epidemic, I guess. What's your take on how that's impacted the Miami Valley of the region?
Dayton and Montgomery County has done a wonderful job of pulling together coalitions to collaborate across organizations and respond to the opioid epidemic. So from 2017 to 2018 to 2019, our overdose death numbers dropped drastically. But then we get into 2020, the pandemic hits, and then it becomes less of, overdose focused on opioids and expanded into other drugs, especially with the entrance of fentanyl into the drug supply, and also just exacerbating general behavioral health and mental health conditions. We're seeing suicide attempts and suicidal ideations through the roof right now. And so much of what we're trying to create for these organizations are data accessibility, visibility, and connectedness, right? We have a lot of collaborations going on, but the silos we're trying to break down are from a data sharing perspective. Where appropriate, of course, within the regulations such as HIPAA, but empowering the organizations to share data where appropriate such that visibility is created we'll just say cross-functionally across all of these organizations that are involved in that care continuum. When you think about the behavioral health continuum and how individuals are interacting with the system, you have the hospitals and the health systems, you have criminal justice systems, and then you have the behavioral health organizations and providers. So it's really creating the connections between those and the communication, the collaboration between those organizations, such that when somebody hits the jail and coming out of the jail, there's care coordination there on the back end to say, get them into a treatment provider or into an appointment. Because often what happens is they'll go from the jail to the hospital, out into society again, get picked up by the police, back to the jail, into a provider, or then it's just the recidivism rate that keeps going like in a consistent circle. And so that's what we're trying to break, is to create the visibility so the communication is happening, but the communication can't happen without the visibility into what's going on within the interactions within the other departments or agencies in the city.
So specifically, what role does Ascend play?
Purely from a data and technology standpoint. So one, we've been able to aggregate data across all those systems. And two, we're building solutions out of that to help drive some of the decision making. So a couple of examples. One of our dashboards that we've built is called Familiar Faces Dashboard. That really allows an agency to take a look at an individual's longitudinal record across all the systems, the hospitals, the jails, treatment, et cetera. What have their interactions looked like over time? And as a familiar face, that's really saying somebody that has high utilization across all systems. So in our top 10%, how can we collaborate on these individuals that have that high utilization such that we can craft programs, services, interventions that's actually going to break that recidivism rate, keep them on the path to recovery.
So who uses that system?
Right now, primarily the recovery board. I'll give you a sense of what recovery boards are. I think that would be important. So every county or set of counties, depending on their size, have what's called a recovery board. They are governed by the Ohio Mental Health and Addiction Services. So they receive funding not only from the state level, but also from the local level, especially if the county has a human services levy. So they're primarily taxpayer dollar funded, and their statutory requirements driven by the state level statutes are to plan, fund, monitor, and evaluate the continuum of behavioral health services. So they're looking at the picture as a whole and figuring out how they can collaborate with other organizations to effectively fund or plan services, and then of course monitor and evaluate them on the back end. So we're providing them with the data and the technologies, the solutions to more effectively do that proactively and preventatively. Most people aren't familiar with what recovery boards are or even aware of their existence within the community, but they play a really important role, especially in planning throughout the continuum. So again, like our whole thesis is, if we can align data and technology with programs and services, we can help these organizations be more proactive and get in touch with these individuals, especially from an outreach and a care coordination perspective, before that crisis event. And these aren't complicated solutions. Like community health is years even behind where healthcare is from a technology perspective. So when it comes to advanced analytics and predictive analytics, like they're not ready for adoption, not even ready to wrap their heads around how to use those types of tools. It's more so like, how do we simply get the right data at the right place at the right time for them to make the right decision is what we're focused on. I'll give you another quick example. We've created out of the real-time hospital data crisis notifications. So that allows us to relay to the appropriate stakeholder in the community if somebody has a crisis event at an ED within the hospital. So if they admit for suicidal ideations, we get that immediate referral, and we send a secure notification through this product we've built to the appropriate provider or stakeholder at the board that then starts the whole outreach process.
So how is that triggered?
Somebody is admitted at the hospital. Okay. The data that we have access to through the hospital is through the health information exchange.
What authorizes you to then share that information with whom?
It's a great question. So from a HIPAA perspective, what we have to pay attention to are the treating relationships with those individuals to allow us to share that data. So we cross-reference it against the claims data of the board to acknowledge that there's an active relationship there with a provider. Okay. And so once we draw that relationship, then we know who to route that notification to for what we call attached patients. However, there's also the applicability within the HIPAA privacy rule to share for unattached patients that we have no record of them having been attached to treatment. So for that, for the purposes of care coordination and treatment, getting them connected, we're able to relay those to the appropriate stakeholders that are providing crisis response within the community.
You've productized that notification service.
Yep.
What's the name of the product?
Crisis notifications.
Notifications.
Yeah, it's pretty simple out of the gate.
It could be renamed.
Could be, yeah, and it's highly scalable. Again, it rides off the HIE. HIE, there's soon to be just one in the state of Ohio, aggregates hospital data across the entire state. And so that's a relative standard data set. What we're trying to figure out is how could it be used to cross-reference against other data sets in the community to route notifications. For example, when somebody's on within the probate court, on what they call commitment, they have jurisdiction to get that individual connected within a treatment provider.
Who's they?
The probate court.
Okay, the probate court has jurisdiction to get
an individual who is on commitment legally connected to a treatment appointment. It's basically a mechanism to reroute individuals away from criminal court into probate court to have more of that opportunity to get them connected and into recovery.
Sure.
The thing is, sometimes these individuals will go back to the hospital and the hospital's not aware that they're on commitment. If they're aware they're on commitment, they will take different actions to say, hey, probate court, I have an individual here on commitment, and they can take steps to get them connected back to a treatment provider. But without that visibility, they don't make that call. So we're looking at crisis notifications in a way that we could morph it into some of these other use cases that look at the continuum as a whole.
Yeah, the implications of access to data like that are pretty vast. A lot of what biases my thoughts when it comes to care for the drug addicted behaviors is kind of the non-criminal treatment addiction. What are the implications of this data for that purpose?
It's all driven towards that purpose. So I'd say Dayton has done an incredible job also of building in programs within law enforcement that is centered around helping individuals get to treatment and recovery, not criminalizing. For example, they have teams that will go out and respond collaboratively that includes a law enforcement officer, but they are not there to criminalize. They are there purely to support. So you have these, again, I'll say cross-functional teams that have a first responder, a law enforcement, a counselor, or a peer supporter that are going as a team to help that individual that is in crisis. So if anything, it's really using the data in a way that can support what they're calling diversion and deflection. And so what that means is they're trying to deflect them away from criminal court and into more of the treatment side.
What's the state of the business? How's Ascend doing? And what's the kind of the big picture view of Ascend and your mission?
Yeah, we've talked primarily about behavioral health. Our capabilities are in data science, UX, and software engineering. So everything is centered around operating within the intersection of those skill sets. We believe heavily in taking a design thinking approach in everything that we do. So we really partner UX with heavily data science and, of course, on the product side in building out solutions with the engineering team. But we have applied that to multiple spaces. So we do the heaviest amount of work in behavioral health, which is why I gravitate to that out of the gate when I talk about Ascend. We've also done work on the post-acute side, working with hospices, skilled nursing facilities, etc. The interesting thing there is they are more poised to talk about more advanced technology. So much of the work we're doing in that space is around predictive analytics. It's giving our data science team especially more analysis stuff on the behavioral health side, but getting to sink their teeth into machine learning projects on the post-acute side.
What would be an example on the post-acute side of some work you've done?
Ohio's Hospice has been a client of ours. Kit Anderson, their CEO, is incredibly forward thinking and visionary from a technology perspective. He approached us in 2019 and
What's his name again?
Kent Anderson. He approached us in 2019 and wanted to build what he was calling an acuity model at that time. And effectively what we developed was an algorithm that can accurately characterize a short stay patient upon intake into hospice, meaning their end of life scenario is going to be within 7 days or less. And so for that one, it's a classification problem where we're saying yes or no, are they or are they not a short stay patient? They had a mechanism within their EHR for the clinicians to go through a checklist of things and make that call. We were able to do it about 10 to 15% better than the clinician with machine learning. So it's got around 80 to 85% accuracy, whereas the clinicians were around 70%. I think the powerful thing there is it's not about replacing the clinician with more accuracy. It's about amplifying their ability to stay focused on the patient care and have the algorithm give them the data that they need to quickly make the decisions. And the implications there are the allocation of resources, right? You have somebody 7 days, that's a short stay. You got to get the resources right out of the gate to make sure that end of life scenario is quality. It's all quality of life. We've built some other facets to it that's able to predict total length of stay, remaining length of stay, so that we can see when those last 7 days are going to be, even if it's a longer length of stay, and are working to build those together collectively into this acuity mechanism that upon intake, we know a lot more about these individuals based on the data from the EHR, the intake assessments from the nurses, et cetera. So that's been probably our first big project, I'd say, in getting into building out and implementing predictive analytics solutions. So it's served as a pretty strong foundation for our team.
That's so valuable. You know, as you get to kind of the second half of life, you've buried a few folks. So you've been called to the bedside, right? And you've been called to the hospice a few times, and it's disruptive, obviously, and you have to put things on hold, and you have to cancel things, and you have to book the flight or whatever, right? And to know that, oh, it's time to come see dad, or it's time to come see grandpa, or whatever, is so meaningful to know they're in good hands, and it's also meaningful for the family to know that it's time to say goodbye. So I can just think of a number of reasons why great data is important.
Hospices typically provide another function called palliative care, which is more supportive care. What Kent has always reminded us of is the saying, all hospice is palliative, not all palliative is hospice. Meaning when you apply palliative care, it's not always an end of life scenario. So while hospice is all about providing that quality of care at the end of life, one of the important things they're working on is getting palliative care more upstream, especially for individuals within the chronic disease populations, to better manage those symptoms in order to reduce the number of encounters they're going to have with the emergency department and things of that nature. So they're doing some really impactful work there, and data is a part of that equation. How do we identify somebody that is eligible or ideal for palliative care further upstream instead of only paying attention to, okay, we're ready for hospice. How do we get the right resources allocated for that situation? Ascend, since 2020, has been able to expand outside of just Dayton and Montgomery County, which incredibly proud of the work the team has done there. So we started out with public health, Dayton and Montgomery County Adamus, but like I said, there's recovery boards throughout the state. So now we're working 12 other jurisdictions throughout the state and working to bring more online. So we've kind of continued to expand that model. From a behavioral health standpoint, I'd like to ideally get out of just working with recovery boards. I'd eventually like us to work with providers from an analytics and product development standpoint.
What kind of providers in particular?
Treatment providers. So the boards are kind of overseeing the entire continuum. They're not exactly providing services.
Okay.
The treatment providers are the ones providing the direct services. I still think there's an opportunity there to work at both levels.
Okay.
But for now, the recovery board need is pretty clear. They historically haven't had data to make decisions. Now we've been able to build the pathways to build relationships with hospitals outside of our ownership structure and get access to that for the jurisdictions we're working within through the state health information exchange. So it's been a big learning process for us, but we're also beginning to further establish what our value proposition is in that public health or behavioral health space in terms of oversight of the continuum and how data and technology drives the design of programs and services. So that part of the expansion is going pretty well. On the post-acute side, we're working with a hospice out of Wisconsin on another tool that is potentially going to be machine learning, maybe rules-based, but it's essentially to allow them to prioritize patients within their workflow. But outside of that, we've been predominantly focused in Ohio for the post-acute work.
So in your expansion in the behavioral health realm, what's your biggest obstacle to get into the provider side?
Like outside of just the specific provider side, our biggest obstacle we're up against is we're doing something that's completely new. So as we're going and advocating and educating within the hospitals, for example, of why they should share data for this use case, it's unknown. There's a little bit of uncertainty with it. So when you have that, there's going to be a little bit of skepticism and aversion to risk for sharing PHI and protected data and all that kind of stuff. So it's been interesting over the last year working through that. We've stumbled in some cases and learned a lot in how to position the use case to get organizations to want to share data and be supportive, because at the end of the day, it's incredibly impactful. It is truly helping these organizations get people connected to care. And we've proven through data that once we get them that initial engagement and connected to care, it reduces utilization on the back end.
Well, what's the compelling value to those care providers, to the hospitals?
It's really the visibility across the board. In a typical sense, everybody's kind of operating in their swim lanes to that point of creating that cross-functional collaboration across all of these organizations. The value is that for the hospital, something coming into the ED for substance use related reasons or mental health related reasons, they're not a substance use or a mental health treatment provider. Some of them have psychiatric inpatient units and things of that nature, but especially for the smaller hospitals, they don't. So getting those individuals connected to care in the community that are suited to provide that treatment benefits them on the back end indirectly, in a sense that it's going to reduce that utilization of the ED for those purposes. For the providers, it's creating visibility in terms of who needs care and knowing that that individual that they're connected with has hit the ED, therefore driving the outreach on the back end to get connected with that individual, come alongside them and help guide them back to getting into treatment.
You're reducing the misallocation of resources, allocation constrained.
That's the one thing any of the organizations across the entire continuum will tell you, is they are incredibly resource constrained. And I mean, that's across all of healthcare right now.
So are you selling to COOs?
In a way, we're typically working with a CEO or executive director, but then they typically have a COO type operator that is responsible for, or a chief of staff that's responsible for really implementing. It's kind of ranging because every jurisdiction has a different setup, especially depending on the size, right? A large Montgomery County is very different than a small rural Preble County.
That's right.
In terms of team size.
So who's responsible for the misallocation of resources depends, greatly depending on how big the organization.
Right. So yeah, it ranges who we work with, but on the provider side, I'd say typically, and especially like within the hospitals, the chief operating officer or the chief clinical officer, or on the hospital side, be more the chief nursing officer,
Sure.
has that broad view of experience in the ED, but also the operational mindset. And if we can get with those individuals, they understand the value. They're not thinking purely from an administrative or operational standpoint. They kind of have that combination of the operational and the clinical mindset.
That's an ambitious objective for the organization. And you're a pretty small organization, a couple dozen people.
We have 18 people.
Where do you see us in like 2 years from now?
One of the things that we've been ideating on is, what do we want Ascend to be? I don't envision Ascend being this big 100-person product shop. I envision us being more of a small boutique consulting shop. Truly can operate more surgically and tactical with the clients to get at some of the niche problems that some of the larger platform technology companies aren't solving. They're not getting to that level of really going through the UX process to identify specific pain points. That's an open market for us that some of these other larger products are not tapping into, because they've identified the products problems rather that they're going to solve, and that's what they're going after. So it opens up that opportunity for us. I'd say, like, ideally, if we can grow Ascend to what we've kind of strategized around, 40 to 50 people would be the max ideal capacity that we would look at in terms of where we would want to operate from a capacity, a revenue standpoint. To answer your question more directly in terms of the next 2 years, where we would want to be, definitely outside of Ohio. One of the leaps we have to make is figuring out how we build relationships and begin to demonstrate the value of this work in other states, which also have a very different behavioral health setup. Indiana, for example. So Ohio is a home rule state. Therefore, for a lot of these people, home rule state, meaning we have authority at the local level in the ADAMHS boards, in the health departments to make decisions for the respective counties. Indiana doesn't. They simply have their state level department, and then they coordinate directly with providers at the local level. So that's part of what we got to navigate is, yes, there's a HIE in every state that we can work on building relationships with hospitals, replicating a lot of what we began to do in Ohio. But that doesn't mean anything if we don't understand the behavioral health landscape, how decisions are made, how resources, funding are allocated, etc. So our goal would be to be more Midwest when it comes to the behavioral health side. And then from a post-acute perspective, we really have an opportunity to work more nationally. Because when we talk about predictive analytics, again, operating more surgically and tactically and finding those needs that other companies aren't solving, we can do that anywhere. It's not reliant or restricting us on our ability to get access to data for the organizations like we're doing on the behavioral health side.
Do you see Ascend expanding significantly beyond behavioral health and post-acute?
So in general, when we talk about community health, like that's a pretty big space and it encompasses a lot of different types of organizations. So what we're working on right now is getting clarity around, okay, we're working in behavioral health, we're working in post-acute. Are there other spaces within the community health continuum that our services would apply to? So we don't have that fully fleshed out yet, but it's something we're working on getting clarity on to figure out where else do we think we could point our capabilities to make an impact.
So yes, I mean, you're going to be opportunistic. There could definitely be places where you could be valuable and you're going to stay.
There's definitely other spaces. I mean, so for example, like Greater Dayton Area Hospital Association is our parent organization. They're also a client. So we do a lot of work with them rooted in the hospital data to look at various initiatives for their priorities. Hospital associations throughout the country that we could work with in that same regard. And I would label that as part of the community health continuum because they're not looking at just hospital. Gadaha, for example, is chairing the behavioral health task force that's launched within Montgomery County. So they're getting involved in various facets of the healthcare continuum, which I would label as a community health organization.
Did you guys get engaged in the COVID problem at all over the last couple of years?
We did. And interestingly, going into 2020, that was a fun experience. So we were in Tech Town at that time, right by the Dayton Dragons Stadium. Yeah, I still remember the week that we made the decision to go fully remote. And it was an interesting time for everybody, just determining like, well, what's that going to look like for our business model? Is business going to drop off? And sure enough, that was our first profitable year as a company in 2020 because we got positioned to participate in a lot of the data-centric work for the community and just looking at utilization of COVID patients across the hospitals, building dashboards to allow these organizations collaboratively across the hospitals, Gadaha, the public health department to make decisions. So we did quite a bit of work with that, purely at just creating these tools to create visibility into what the utilization looked like. The majority of our team does not have experience or background in healthcare or community health, except for our two senior accountant project managers. One comes from the health department world. The other comes from the behavioral health world. So we have been able to hire two subject matter experts in the space that have created so much value. So we're not flying in blind because none of the rest of us understand the space fully. I mean, I've been with Ascend for 7 years, and so I picked up a lot. But to help really navigate the behavioral health continuum, especially, like, it's complex. There's a lot to understand.
So you've got a couple of healthcare experts, and then the rest of your team is mostly technical and analytical experts.
Yep, data science, UX engineering, some accountant project management folks that have the subject matter expertise in the space.
Okay.
A product manager, that pretty much makes us a team. Then you got me. I do
The math guy.
the math. No.
Okay.
What was your background again?
Well, yes, math and operations research, but I definitely would not consider myself a mathematician. I'm much better at leadership than I am data science, I think.
Sure. You grow into these things and you forget the old tricks, I guess.
Yeah, that's right.
So you were saying your 2-year vision or goal is about expansion and kind of taking these capabilities that you've developed in both behavioral health and in post-acute care, thank you. Taking those capabilities and expanding into other states. What's your biggest obstacle to, kind of meeting those goals or objectives?
I think one, we still need to get crystal clear on our value proposition in the behavioral health space.
Okay.
All right, we've definitely centered around this value in creating access to data and building solutions from that. But I think there's a more holistic story to tell, which is why we are kind of traversing our way towards the state level. Had a wonderful conversation yesterday with the Ohio Mental Health and Addiction Services, who had no idea of what we are doing for the recovery boards as they ultimately oversee. So that was great from a building awareness standpoint. So we have steps within Ohio to take to show that, like, if we were able to do some of this work at a state level, the impact that it can make. So one, clarifying that value proposition and making it really clear, especially at a state level, what we believe we can do. And we're tapping into some funding sources that are coming up, driven by the American Rescue Plan Act funds that are going to behavioral health, that I think we're going to really be able to accelerate some of our work. The second part of that is we have a lot of work to do still to get these organizations ready to adopt data strategy. So that's why we haven't jumped to predictive analytics in the behavioral health space, because we're simply trying to get them equipped to think from a UX perspective, to think from a data science perspective. So I think we're still building out our ability to effectively, for lack of a better phrase, build a maturity model.
What kind of work? What's that involved?
Yeah, it's purely working with the organizations and the team to get them acclimated with what it means to make data-driven decisions. And oftentimes they'll stare at a dashboard and say, well, what do I do with this? And that's why we work hand in hand with them from a UX perspective to build out those dashboards so they're involved in the process of creation and getting to see as it comes to life, like, oh, okay, here's the needs I communicated. Here's how that translated into features within the dashboard of the product. And now I start to understand how I can use that data to drive my day-to-day responsibilities or workflows, operations, outreaches, etc. Kind of hand-holding and guiding a little bit through that process to get them the vocabulary and the knowledge they need to at least be dangerous.
I talk with a lot of folks who are in the data space, and, the UX work is oftentimes tricking people into making emotional decisions that are based on data. Because everybody actually makes emotional decisions because we're just so hardwired to make instinctive or emotional decisions. Mm-hmm. It's like you just feed the emotional wires that are already in there, these instinctive ones, which even the emotional ones are data informed. We're just hardwired to do it this kind of instinctive way, right? Which our brain, for whatever reason, thinks that that's the best way to get data.
We're very perceptive as human beings, and our perception creates our reality. So it's kind of a game from a UX perspective of identifying, those perceptions across an entire team, getting alignment on ultimately what we're trying to achieve, such that we can feed data in to that process of kind of the human in the loop aspect of making decisions with data. Because ultimately, we're never going to drive any of our solutions towards replacing roles within an organization. I think it's amplifying their ability to make decisions. And that's kind of how we're positioning everything that we build.
It's an ambitious goal that you and the organization have. The outcomes that you're intending to create could have a huge impact on, theoretically, millions of lives.
And that's part of the other goal that we have to achieve, is to be able to get really good data on outcomes. We've got to be able to prove consistently that these solutions lead to improved outcomes. So that's something we're working on as well. We've got a lot of case studies going, a lot of pilot programs going to be in collecting data and actually showing objectively how this is reducing utilization on the back end, or how many people, because of those crisis notifications, have we gotten connected to care, and starting to build that story of what could be if we're able to expand the footprint of this work being done.
I'm just going to assume that you'll keep building longer than the next 2 years. That'll keep happening for decades.
Yes, and like if you were asking me a 5-year plan, I'm not sure yet. We've just been evolving so quickly and kind of learning and iterating as we go that I'm not sure where we're going to be in 5 years. But in the next 2 to 3 years, I definitely have that vision set on getting much more focused on a larger swath of the Midwest region and getting outside the state of Ohio. If we can traverse that and figure out how to address some of the differences in how the states operate from a behavioral health standpoint, I think we'll come up with some viable solutions between now and then that are scalable and will give us that catalyst into expanding even more to a national level.
Maybe in a couple of years, I'll have you back on the show.
All right. That would be great.
Very good. Thank you for being a guest.
Yep. I appreciate you having me.
All right.